One of the most feared complications of gallbladder surgery is actually a bile duct injury. And the biggest problem is 97% of this is secondary to misidentification. So today we're actually going to talk about how to have zero bile duct injuries, ways to prevent them, and we're going to talk about the 5 steps in order to get good exposure and prevent misidentification. Let's get started. So whenever you're doing gallbladder surgery, you have to understand the goals of the surgery. And I try to keep it simple. Number 1 is to alleviate the symptoms. What does that mean? Well, your goal is to ideally remove the gallbladder, but in certain cases, if it is unsafe and you're going to be at risk of causing a duct injury or any other major structure injury, then you may consider other bailout options, which we'll talk about later. The number 2 is preventing said injuries. So alleviate the symptom, whether taking out the gallbladder completely or doing a subtotal cholecystectomy. And number 2, which is also as important, is to prevent any major bile duct or vascular injuries.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
So how do we do this? Understanding the 5 things, which I'll talk about step by step, your first goal is actually exposure and visualization. How do we get exposure? Most people put their ports in the umbilicus, but that doesn't work when somebody's morbidly obese because sometimes their belly button's down all the way to the floor. So in this instance, you want to have a good placement of your ports. And so if we actually draw the abdominal wall here and you draw the subcostal, ideally, the gallbladder is actually not a midline structure. So putting your port around the belly button is actually not a good idea when you're trying to dissect in the right upper quadrant. I personally put my ports up here in this area, wherein that would be around a palm, if they're very morbidly obese, between a palm and a half, away from the area of dissection. Because when you put it too low or over the umbilicus, if they're obese, you may be behind all the omentum, small bowel, and transverse colon. And so you're now pushing up the camera to get over this hump, and then you're trying to look all the way down to your infundibulum and your hepatocystic triangle, which is going to be difficult. By putting it at a higher spot and then looking forward and downward, you're looking straight into your target dissection plane. Number 2, so that's going to be port placement for exposure. Now you're getting started. And one of the difficulties is exposure of your structures. And the structures that you do want to see is, number 1, it's going to be your infundibulum. And so when you draw the gallbladder, this is going to be your cystic duct, and this is going to be your infundibulum. This is your body, and this is your fundus. The fundus is retracted cephalad, and majority of the times is going to be in the right upper quadrant. You have to be able to see this structure because this is going to be your hepatocystic triangle, where your dissection is, and your other tubular structure, which is your artery, is going to be in there. So when you're unable to get optimal retraction and visualization in the area, you could decompress the gallbladder. So if it's very distended, you're able to handle and manipulate it better. And number 2, if that's not enough, you can actually cut the falciform ligament. You can detach it. Why do you want to detach it? So here's going to be your liver and your falciforms up here. If you've noticed, when you do a very difficult gallbladder and you try to push up really hard, it usually causes a capsular tear in this area of the liver. And so by detaching the falciform, it actually gives you an additional push to avoid that tear and allow further retraction, giving you a better exposure. So now that you've done that, the question is, can you do the gallbladder safely? And that's going to be multiple options. If you're doing the gallbladder safely, you should be able to dissect in the hepatocystic triangle and be able to peel off all the areolar tissue to only show two tubular structures going into the gallbladder after a third of your cystic plate has been dissected, and you could see the liver through this window. That is the minimum. The important thing is, when you're having faced with a difficult dissection, other options include detaching the gallbladder completely from the plate. It's like doing it open. There are a lot of tips and tricks in that one. And one option is you should be able to dissect here first at the hepatocystic triangle, because if not, doing a top-down approach is unsafe or will not prevent you from getting into an injury, because if you go off plane from the cystic plate, you would actually go all the way down to your porta hepatis, which will then lead you to a right hepatic injury unless you extend it all the way to their common bile duct, and you could have vascular injuries on top. Another important thing is you want to detach the areolar tissue as close to the gallbladder, because here sometimes your origin of your cystic artery, which is your right hepatic, may be closer than you think. And so if you're unable to dissect this safely and it doesn't open while you're dividing the tissues, you don't want to take that risk. And you have to understand what bailouts you have. By actually detaching it from the gallbladder, you can peel this off better and get better visualization if there is a lot of chronic inflammation prohibiting tissue separation safely. So we do the top-down approach as number 4, which is in combination of a typical dissection of your hepatocystic triangle. And lastly, you have to know when to bail out. Bailing out is not an admission of defeat, but actually a very important tool to prevent the patient from getting a major bile duct injury, because your goal is to alleviate the symptoms. Okay, why does a bailout matter? When you do a bailout, I personally prefer doing a subtotal cholecystectomy, and that is a fenestrated subtotal. If you do a fenestrated, when would I consider doing a bailout? When you can't expose your infundibulum because of chronic inflammation. That would include the transverse colon or duodenum attaching to it and prohibits safe dissection. That's number 1. So if you can't see this one, with all the things that you've done, converting to open doesn't really change a thing. As long as you have good laparoscopic skills, you can actually figure out, can I do this safely laparoscopic? Even if I open, I would probably end up doing the same, or I don't want to push it and then lead to a bile duct injury either way. The next one is, if you can see the infundibulum, you want to make sure that this area, which is the hepatocystic triangle, can be dissected. What do I mean by that? If you've cauterized the tissues in this area, and you can identify the hepatocystic triangle, then the biggest problem is when the tissues are so inflamed that they won't even separate. It's like cauterizing a leather boot. You don't want to keep on forcing that. Your option is either continue the dissection cephalad and increase your exposure, do a full top-down approach if you can get it safely. But if it doesn't open because it's so chronically inflamed, try to pursue a dissection here may actually lead you to a vascular or a bile duct injury because you don't have safe dissection. And so cutting the front wall of your gallbladder will actually allow it to be defunctionalized. So why do we do that? Looking back at the pathophysiology of cholecystitis, you have a cystic duct obstruction. And so if there is a cystic duct obstruction, what happens is there is now a buildup of pressure from all the mucus that's secreted that then leads to hydrops. And if that actually occurs, this will lead to congestion until it progresses to necrosis and then perforation. Then why would we cut the front wall of the gallbladder? If you do, this now becomes an open organ that allows tissues to be decompressed, preventing the progression of further necrosis or perforation, relieving the inflammation. That's number one. Number two, I leave it open and leave a drain because of two things. One is if you see bile spilling, that will control the bile that is spilling until you get the ERCP. Or if there is no bile spillage, you still want to leave a drain in place because that inflammation from the cystic duct may actually relieve itself once the inflammation is gone and subsides, and you may have a delayed bile leak. We actually look at the drain until 2 weeks on follow-up in the clinic. If it's clear, then we take it out. And if not, then we bring the patient back in for an ERCP. Or if that actually occurs earlier while they're in the hospital, then we do that in-house to prevent or help control the bile leak. In that aspect, you prevent any major vascular or bile duct injuries. Well, let's put it this way. Why do we care so much about preventing injuries? Injuries can be fixed, and injuries can lead to a Roux-en-Y hepatococyginostomy. That means if you transect the bile duct, just go to the main bile duct, the common hepatic duct. If you transect it and you do a Roux-en-Y hepatococyginostomy, number one, you are prone to actually having recurrent stenosis. And this goes up to 93% in 7 years. That's pretty bad. Number two, when you have an anatomy that's different like this, you're actually prone to cholangitis as well. And with those two, these are also risk factors to developing cholangiocarcinoma. So that's why we do care, and I put that as symptom relief, either doing a total or a subtotal cholecystectomy. Number two priority is prevention of injuries. And so that is why you have to understand when to do a subtotal. Again, unable to see the infundibulum, unable to safely dissect because of chronic thickened inflammation and the hepatocystic triangle precluding safe dissection. So those are the important things you have to understand when doing gallbladder surgery to actually keep you safe from injuring a patient. Because as much as we do want to help, we want to prevent major injuries, which is worse than what they came with as their initial pathology. If you guys have any questions, any thought process, please type them in the chat. I'd like to understand what other people do so far in our practice. I've been in practice for 10 years, and knock on wood, we've taken good care of our patients with 0 bile duct injuries. Thank you very much. Check out the other videos talking about acute cholecystitis, and I'll see you guys next time.